Thank you for joining us this morning. And I just wanted to say good morning, good evening, wherever you are. And I look forward to our talks, and hopefully this will be very educational. So our topic is on ergonomics in eye field, in both in ophthalmology and optometry. But this is going to encompass just not our particular field, but it's going to encompass the entire profession of medical specialist. And this is sponsored by the cyber site of Orbis, which I'm very proud of. Very proud to be part of. This is it's a free access educational platform for all the experts around the world, and I think we're almost at 100,000 members. So this is one of the largest medical platform for the field of optometry and ophthalmology, and anesthesia and nursing, and all the fields that are associated with the eye fields. We have free AI programs to help you to make a diagnosis of various retinal findings, and also we have free access to ophthalmology experts all over the world for your complex cases. And we have online courses and libraries. So please feel free to take advantage. Without further ado, I'm gonna introduce our three amazing speakers. We have Dr. Benjamin Young, who's a assistant professor at the KCI Institute in Pediatric and Adult Retina. He's an excellent speaker, and he's been very active with the AAO webinars. And we have Susan Ksiazek. She's a double boarded in neurology and ophthalmology, and she has given numerous talks on this particular topic of ergonomics. And she's currently in Wisconsin with Marshfield Clinic. And I am, here at the University of California, Irvine, and I look forward to interacting with most of you here. Okay, first question. What do you do? I would like to have some background of your specialties. So most of us are optometrists and ophthalmologists, and we have some students and surgical techs and some of the others. Okay, perfect. Next, how often do you experience back pain? 1 through 6. Never, rarely, occasional, frequently, daily, only during certain activities. Okay. So occasional to frequently, perfect. So now we're going to go to the next one. How often do you exercise? 1 through 7. Be very honest, please, because we want to have the most accurate information. Daily, several times a week, once a week, several times a month, once a month, rarely, never. Hopefully, none of you vote on never, but we'll see. Okay, so I think there's definite room for improvement. That's great. Last question. This is an actual question that was brought up by Susan. Who may experience more pain? For those who have practiced for many years, or for those busy surgeons or optometrists? So most people think that it's the people with higher volume. So Susan's gonna demystify that. Oh, sorry, one more question. What is poor ergonomics associated with? Back pain, headache, carpal tunnel syndrome, musculoskeletal disease, anxiety and depression, burnout, and wrong site surgeries, or all of the above. I'm going to tell you, it's actually all of the above. It can lead to anxieties and depressions and burnout and medical errors. We'll just briefly touch on that later. So I'm going to stop sharing my slides, and we're going to have Susan Ksiazek present her first talk.
Okay, good morning or good evening. As Dr. Suss said, we're going to talk about the clinic and ergonomics in the office. I have no disclosures. So just what we're going to touch upon is the chair, meaning your chair, as well as the patient's chair. And we're going to include wheelchairs in this because often there are some patients who cannot transfer. We're going to look at our slit lamp positioning, indirect exam, and also our workstation. Compared to family medicine, we are more than 2.5 times at risk for hand and wrist pain. Certainly we are at times, surgeons is contributing to that, but also we see a volume of patients that medicine doesn't see. We probably see sometimes twice as many patients in a day as they do. We're also 3 times more likely to get lower back pain. There's a survey, and there's several of these we're going to talk about. What I want you to notice is that they're all about 50%, over 50%, but there are half of us working who are experiencing pain in some portion of the body. And they also, a certain percentage, 15%, says it does affect their work. Maybe they cut back, they take time off, or something else happens. This is actually personal for me. Full disclosure, 6 years after starting practice, I had neck surgery for a C5-6 radiculopathy. And after that, I became highly interested in how to take care of myself. And certainly some of the bad postures we're going to talk about contributed to my injury. So this is the question that Dr. Sam mentioned, and who has more pain? And certainly number 2 won out, but the answer is number 3, is that we are not exempt. As I said, at 6 years into practice, I was relatively young. I had gotten several whiplash injuries, was lifting poorly, and then contributed to using the slit lamp and the microscope. So seeing more than 100 patients a week puts you at greater risk. Performing more than 4 surgeries in one day, or 6 lasers a week. 6 lasers a week is like 1 per day. 100 patients is like 20 per day. And of note, age was not a risk factor. So prevention is key, and it's an occupational risk. And again, remember we talked about the 50%. So the surveys in 2004, as well as in 2005, over 50% of people had neck or back pain. Those are the bigger ones. And some had surgery. So they noted back surgery, no neck surgery, but back is certainly the more common one that's done. A more recent survey of plastic surgeons, and this may relate to them bending over, and I think Dr. Suss is going to cover some of that in his lecture with pediatric surgery, but the bending over may cause an increased risk of neck and back problems. So in the office, with the patient's chair and the footrest, you have them get in, you cannot get close enough to the patient because of your casters doesn't fit under that footrest. So the first thing I do is seat the patient, clean my hands, and raise that chair up. I raise it up. I just do it, you do things by routine and you don't even think about them. This enables you to get closer to the patient. So in the first 2A, you can see he's leaning into the patient. He's got hyperextension of his neck and kyphosis of his back. So he's really injuring both parts of his spine. In the second 2B, he's pulling the patient towards him. And sometimes the patients will complain a little bit, but just think, they do it once and you do it 20 to 40 times or more in a day. So just say, please lean forward. In fact, you can see how raising the the chair allows you to get the chair closer to the patient. I even have, when I'm checking APDs, if I don't have the patient lean forward, I feel like I'm leaning on top of the patient. So again, APDs, can you lean, like you need to check it. Your tech says, no, I think I saw one. You go in, have the patient lean forward. Often they will do so briefly and not complain. So here it is. You want to make sure your ear is over your shoulder, is over your hip. See that very nice posture in the first slide. You're having the patient lean forward. And here I'm also I'm not making full use of my backrest, but if you have chairs with backrest, that's another thing. You know when you lean off the backrest that you're leaning forward. And you may consider getting some sort of cushion or pillow for the patient so they can not have issues with leaning forward. Some of them, I don't use one. I find I just ask them to lean forward and they do so for me. So some people have even gone to the extent of getting a custom table. So if your table length is shorter, or the width, so to speak, is shorter, there's less, you can lean in easier to the oculars. The other thing I would consider is making it wider, and I'll show you why in a minute, but custom tables is a way to go. The other thing when you use the slit lamp, this is a big no-no, and you sometimes see this in female physicians or optometrists where they're wearing a skirt, and so make sure you don't do this. Not only are you leaning, you have torsion to your spine, so this is really not very good at all. So don't cross your legs, put one on either side. Also, just a quick hint, if you are examining the right eye, you want to be to the left. And when you examine the left eye, scoot your chair to the right. Again, avoid that torsion. Same thing with lasering. If you're doing the right eye, put the foot pedal on the right. That way you balance your body as opposed to leaning always way over with the hand and the foot doing both. Holding your wrist. He's leaning on the metal bracket of the slit lamp, long hand, he's flexing, not good. Just the opposite in the second picture, hyperextending, not good. You want to be neutral. And notice there's a cushion under his elbow. And there are various cushions available. Don't use the wooden one. The wooden one is out there. It's too hard. The biggest problem I see is that these cushions are too wide for a slit lamp, so they often want to fall off. The one on the left doesn't. It's a little bit more narrow. So you can find these. They're available. Or you can sort of jerry rig your own. A word about wheelchairs. So we talked about your slit lamp, the patient coming up, your chair using a back, sitting straight. But what about the patient that comes in and can't transfer? And I transfer as many patients as possible. Wheelchair glides do not make this better. You're leaning forward, again, your back is not in a good position. You're not in alignment. Your neck is hyperextending, not good. I actually noticed just this past year when I was doing this, I had a problem and my neck started acting up. And I knew it was every time I had a wheelchair patient. I had a retinal problem. They were bad diabetic, and I needed to do a very intense exam. So my manager, I give him credit, said, okay, we're going to take, and the problem with this is you need a dedicated room. You take the chair out, you raise the floor. Ours is a little over 3 inches. And we have this lightweight plastic ramp, which was very reasonably priced. You wheel the patient up and instantly they're at a higher position for you, like as if you raised the chair. So you take the ramp away and then you can examine the patient easily. The biggest issue, as I said, is you have to have a dedicated room for this. You no longer have, you can put patients in regular chairs if you wish and examine them, but you don't have your eye chair anymore. The indirect exam. This is terrible. And this is something you see in the OR as well, and because you're hunched over and leaning. And also in the right picture, contorting your body, not only leaning, but you're twisting. This is not good for your body. And if you're not going to have a good career if you do that. So lessen your load on the neck, raise the chair, lie the patient down, and go to right side, go to left side. This takes time, and that's the problem we have. Sometimes we want to be as efficient as possible, and we hurt our body in doing so. What about your workstation in the room? It's better to excuse yourself finish typing, and then turn and talk to the patient. Not like the patient, not like the doctor in the far right. That's not good. Completely turn your chair around. So none of these pictures are ideal. In 1A, his chair is too low. His arm should be at 90 degrees. In 1B, he's turned. His spine is not straight. 1C is pretty good, but he's not taking advantage of his back of his chair. The articulated computer for the keyboard, the articulated stand is nice if you want to swing it and type while you talk to the patient, if you can get that. If you can't, just excuse yourself, type, then turn and talk to the patient. I usually say, first I'm going to examine you, then I'm going to type, and then we'll talk. So they don't get upset while I'm quietly typing away. So at your workstation, remember 90 degrees, your ears above your shoulder, above your hip. You can actually buy a cushion if you're not right. So you can sit on something to raise you up. You might need a footstool if you have short legs. You don't want your mouse too far away. That reaching is very hard on your shoulder. Make sure your feet are not crossed, they're straight and flat on the ground. There was a question early on about how do you set up your workstation? So when you're setting up rooms, you don't have an office yet, I would suggest for right-handed people, you put your workstation on the left as you walk in the room. That way you can turn to your right, and vice versa. But you should do all your rooms ideally the same. You shouldn't have one room on the left and one room on the right. That's when you're going to run into problems. It's that routine that helps you. And remember, during this webinar, I hope you leave with good ideas to prevent and treat your pain, but you want to be in that good half. You don't want to be in that 50% that has problems. And when it comes to long overtimes, make sure you take breaks. We tell patients 20, screen breaks. We need to take breaks. You need to stop and walk and stretch, just stretching your arms. And I think Dr. Young will talk something about that. And somebody mentioned eye protection. I think of eye protection is something that I avoid sun. Or don't let sun come into my eyes. Brimmed hat and sunglasses, that's my sunscreen. That's how I keep my eyes healthy for my life. And I tell my patients the same. Also taking breaks, 20. Every 20 minutes, look 20 feet away for 20 seconds. Remember, also, it's not just at work. Maintain your good posture throughout your day. Remember, you're driving. Use your side mirrors. Lifting, that's how I got myself into trouble. I was lifting too much or lifting poorly. All of these things are important to consider as well. My references. Thank you.
Thank you, Susan. Great talk. A lot of great tips. Next, it's a great segue to Dr. Benjamin Young. Is going to be talking about what are the things that are important outside of work, at home, and what are the important habits that we should consider. So, Ben, please take it away.
Great. Donny, thanks again for the invite and Cyberset for hosting this. Something, topic I really care about and excited to talk about. So, how do we improve our ergonomics when we're not in the clinic or the OR, which is what Susan just covered and what Donny will cover in a bit? What can we do, away from work? So no financial disclosures. We just had this poll question come up, and it looked like, at 94% of people had back pain with some frequency. It was only 6% never had back pain that were logged into this talk. So, obviously this is a very common thing that happens. Just a little brief intro to myself. It's kind of a similar-ish story to Susan in terms of like why I care and investigate this. So, you could probably tell from the video, I'm like, relatively young, early in my career. But early on, I knew I wanted to manage retinopathy prematurity. That's not a picture of me; it's just a stock image. But as most of us know, ROP exams, along with many things like plastics and peds ophthalmology surgery, but RP exams and really like indirect laser, I saw pretty early on, forces you into really uncomfortable positions. You have to really maintain with your neck and back for long periods of time. And like early in my residency, like as early as my PGY2 year, I was in my mid 20s. I was already getting a lot of lower back pain. Just like Susan said, age is not really a factor. People at any age can get musculoskeletal skeletal issues. So, since that, I'm about 8 years or so beyond that, we'll go on kind of my evidence-based tour of what I've been trying to figure out so I can have a career that's more than like a year or two and then still be able to treat, adults and babies. Okay, first, I want to review some basics of the spine because I think I had a lot of misconceptions about what's important. So, spine, we all should know, is a column of bones separated by fibrocartilaginous discs, intervertebral discs. Um, the spine, from an evolutionary perspective, was designed to be really good for rotational bending and lateral flexion. So it's good for like when cats bend to clean themselves, or really when we evolved in the ocean and our back and forth movements with aquatic animals. That's what like the spine is like really good at. The intervertebral disc anatomy is designed for it. It's not designed, or was not for millions of years evolved to tolerate compressive load. Even when we came to land, the spinal column was really well designed to tolerate moment load. So like in the sheep on the left, the load from like the weight of the gut pulling down, the spine is pretty good at tolerating that based on its arch and everything. But in terms of bipedal animals, it was not designed for that initially. As a result, if someone has back pain and they go see whoever, and they end up getting an MRI scan, the majority of humans, something over 90% of humans, will have some kind of quote degenerative change in their spine if they get imaging. Like mild herniations, thinning, bony spurs, etc. So that's just a fact of life, that even if you have no back pain, you go in, you could still have these changes over time. That's important to know from the outset. Um, in other words, because our anatomy is likely not optimally designed to be in the position that we're in, we're constantly in a war against gravity. So, the goal of what I'm going to talk about, really what all three of us are talking about, is to be able to generate force to maintain the appropriate intervertebral relationships so that your spinal column can tolerate that compressive load it's not really designed to do well. In other words, like that's a lot of words. Basically, what I'm saying is a strong back is a healthy back. If your back is strong and able to isometrically contract to keep the spine in a neutral position, in the positions that Susan was just talking about, and Donny will talk about how to maintain that neutral position as well as possible, then you're going to have a healthier back in general. And I'm talking mostly about back pain. The idea that strength helps to protect your joints, it applies to all joints, not just your back, shoulder, elbows, wrists, etc. But remember, strength. I'm going to talk about strength for a lot of this talk, and I know we're not orthopedists, right? I don't think classically ophthalmologists are really into strength training or whatnot. But remember, strength is just the ability for your body to exert force against the outside world, and that's what's important to be able to protect your spine and your other joints. So what's the evidence behind this claim? Susan went through some with specific to ophthalmology, but there aren't a ton of huge studies that look into this specific question. So I started looking at other specialties. This is a big study of urologists, 700 some urologists, and basically the summary of these graphs are that the statistically significant fact that they found when they looked at many factors like age, duration of career, surgical volume, and exercise, is that exercise was protective, and the rest, like Susan said, like age actually did not have a strong factor that was related to development of musculoskeletal pain, back and neck pain. This is we get compared to dentists fairly frequently for many reasons, but this was a nice study looking at the effects of resistance training for dentists and dental assistants. And again, summary is that after a 20-week course of doing, resistance training, strength training, there were improvements in pain in, all these joints, neck, upper back, lower back, and shoulders. This was a nice literature review in occupational environmental medicine, looking at not really even specific to medicine, but all occupational musculoskeletal disease. And they found that the strongest level of evidence of being able to develop an interventional program that was protective against musculoskeletal injury was resistance training. Other things were helpful, like flexibility training and stress management, et cetera, workstation adjustment, all had, moderate effects as well. But the one that kind of ran through many different occupations was resistance training as strong level of evidence as being protective. And this is just, like Susan mentioned, it goes beyond, neck and shoulder pain. If you are doing strength training, headaches can be reduced too with effective training programs. So, I'm talking a lot about exercise programs. I haven't talked about what those look like. Again, based on kind of this literature, here are some things that I would look for, because I'm not going to prescribe a specific one. All of us need something different. All of us have different, equipment and such that are available. But here are some broad things that I would consider if you're convinced by my pitch that we should all do some degree of strength training. Okay. Number one, compound movements are better than simple movements. So when I say simple movements, I mean a movement that's isolated to a single joint. So on the left, that's like a leg extension. It basically just works the quad muscles. That's compared to something like a leg press, which I have on the right, where it works, across two joints, the hips and the knees. In part, this is good because we're busy. All of us that are listening to this are busy people, and the fewer exercises you need to do, the more efficient your workout program will be. The other thing too is that you want to, if your goal is injury prevention, you want to balance out the muscles that are doing the different activities. So if you're only working your quadricep muscles, not like your hamstring or your posterior chain muscles, then you might not have that balance, and you won't, may not be as effective at injury prevention. Take that a step further. In general, free weight exercises appear to be better than machine restricted exercises. So, instead of a leg press, doing something like a squat where you have a weight on your back and you go up and down with gravity, it's likely better. The reason for that is when you do a machine restricted activity like the leg press, depicted on the upper right, then that doesn't kick in the use of the smaller stabilizer muscles that you need to do in real life to do that, activity. In real life, we're never doing anything that we're restricted in the machine in, a single plane of motion. We're twisting and torquing, etc. So your body, if you're going to train your body to try to, again, win the war against gravity, you need to be able to use all the muscles in realistic situations. So I would recommend, if you can, using free weight activities compared to machine. Also, this is maybe this may be the first time you've heard something like this, but I would also suggest avoiding exercises that induce spinal flexion. So that's, setups. I think at least in the United States, we all learn to do setups, and we do a lot of them like in grade school. But the purpose of the spine is really, it can flex, but again, the purpose of the spine is the core muscles that the abs and the back muscles is really should be isometric contraction, again, to maintain the neutral intervertebral relationships, like Susan was demonstrating in terms of keeping the spinal column neutral. That's what you want to do. So doing things like setups to try to, quote, strengthen your core, is not as effective for that. And if you've ever had back pain, and I really suggest not doing it, because you may have bony spurs or degenerative disc issues where you may exacerbate them by doing spinal flexion. So you want to do isometric contraction where you keep your spine neutral. The last idea that I'd suggest when you are browsing around for exercise programs is to look for something that involves progressive overload. So I think that the most succinct way to explain that is this cartoon depicts the myth of Milo of Croton. If anyone knows that Greek myth, he was like a famous mythological wrestler that had many feats of strength, in Greek myth. And the story of how he got so strong is he had to carry a calf, like a baby cow when it was little, and he had to carry it up a hill every day. And the cow would get bigger and bigger, and he was still able to carry it, up that hill, because your body will adapt to changing stress. You know, it's just like when we're learning cataract surgery. If you do like 100 routine cataract surgeries, you're probably not going to get better once you get to a certain level. It's when you start doing more and more challenging cataract surgeries that your skills will improve. So if you're, you know, trying to train a muscle, definitely don't start off with like the full size cow. You want to start off with something light that you can tolerate, but then you have to also progressively, at a very gradual rate, increase the amount of stress that your body is overcoming to be able to force it to adapt to increase strength and ability to exert force on the outside world. So look for something that involves that. If you're just doing, you know, 10 sets of push-ups every single time, you're actually not going to get stronger. You're going to maintain strength. And then don't forget, we don't get stronger. We don't, our spines or backs or necks don't get stronger when we exercise. They get stronger when we sleep and hydrate, eat well, and rest. You know, it's not during, it's when our body adapts after the stress has been applied to it. So those are probably the most important things to remember when you're exercising. Don't overdo it, and make sure you do those things in red. Okay, so you know, the poll question, we found that a lot of people, actually more than I thought, were able to exercise routinely. But you know, I'll tell you, you know, I'm like early in my career and I, you know, just had a baby. It's like hard to find time, I think, for a lot of us to exercise routinely. So I tried to search as much as possible for exercises that are the most efficient use of time so that, you know, we can get in and out and accomplish our goals. Um, and my conclusion was that a barbell deadlift is probably the most efficient surgery if your goal is ergonomics and injury prevention. If you're looking for like bodybuilding tips, don't ask me. You know, you can't maybe tell in the video, but that's I'm not your expert on that. So here's what a deadlift looks like. Here's just a quick video. It's just taking a weight from the dead stop on the floor. That's where the dead comes from, and bring it to standing height. You know, that's it. Good technique is everything with this. You know, as you can imagine, if you're doing this wrong, if your spine is not neutral the whole time, if your technique is off, then you can hurt yourself. But if you have good technique, you won't hurt yourself. And you know, I mentioned in the beginning, you know, I had back pain, you know, very early on in my training, and when I figured this out and started doing deadlifts regularly with, again, progressive overload and increasing strength over time, I haven't had back pain since. So you know, take that for what it will. I'm not saying that that's, I don't have a large study to show that. There are smaller studies that suggest that that's a common finding, that strengthening the back with this technique can reduce things like back pain. But you know, this is what I found was helpful. Because the reason I don't think I mentioned is a deadlift basically works the entire back. You know, basically the entire back muscles, the posterior chain muscles. You know, forearms when you know you're trying to strengthen your wrists, etc. But remember, doing any exercise, according to the literature review I did before, is better than nothing. So, you know, if you don't have the equipment for this, which you probably don't unless you have a gym subscription, any kind of exercise we should go into in a bit is better. And to be super clear, you know, age is not a factor in whether you can do this or not. I know this technique may look scary, but you know, this woman is lifting. This is more, if you don't know weights, this is more than I weigh. This is like 225 pounds or so. You know, you can, if you can, you know, walk, then you should, and you don't have serious prior back injuries or whatnot, then you should in theory be able to do this. But you know, examples of training programs, this is like the most simple one. Again, it doesn't have to be like 1,000 different exercises, you know. And you know, in this, like the thing called a press, where you push a weight up, or bench press where you push a weight forward, you could probably skip that if your goal is just ergonomics. This is the program that I did, that, you know, that got rid of my back pain. But again, I don't think anyone specifically studied this one, but it can be just a couple exercises that you do 2 days a week. If you don't have access to, like, you know, the more fancy equipment, some home equipment that you could get are things like kettlebells. You know, those, you can do a lot of free weight type activities that can help strengthen your, you know, your core. You know, dumbbells, you can get adjustable dumbbells that you can vary the weights. You don't have to get a whole set. You know, if you're office or home or whatnot. If you want to do a simple, like, just body weight routine where you need no equipment, there's a lot of different versions out here. This is just kind of follows the principles. These three follow the principles I was talking about. I won't have time to go through exactly how to do each of these. Here's a QR code that links you to this, or you can just search McGill Big Three. That's just one kind of set of exercises that you know, that seems to be very reasonable. That's recommended by physical therapists. But again, the key to this is that we're not inducing repeated flexion on the spine. We're keeping isometric contraction on the spine in different positions to strengthen it to, to prevent injury. So in conclusion, when you're not at work, if you can find time, a couple times a week, once or twice a week even, to do some kind of resistance exercise. Again, any exercise is better than nothing. A lot of aerobic exercises also will strengthen, isometric contraction for your spine. And then don't forget sleeping and hydrating well are critical. And that's all I have. Thanks, everyone.
Thank you, Ben. That was awesome. Only thing that I'm doing that you have recommended is that I'm not doing any sit-ups, so I'm in good shape. Well, thank you very much. For next 15 minutes, I'm going to be giving a talk on what are some of the things you can do in the operating room. So I have no financial interest in any of the things that I'll be talking about. I've actually looked at different surveys, and I have taken surveys from a different source of ophthalmologists, and I found the numbers were actually even higher than Susan's. So it's almost 80% of low back pain, and the numbers were even higher among pediatric and plastic surgeons, oculoplastic surgeons. And why is it so high? Because ergonomic posture is not something that's natural. We have to consciously think about it. Just like what Susan and Ben talked about. Our instinct is to tilt our head and twist the body to get close to what we're doing. And unfortunately, we're working on an organ that's very small. So in order for us to see small items, small things, we have to get close. That's just the human nature. We want to get close because as long as you can accommodate. But of course, if you cannot accommodate, or if you need some additional assistance, then we wear telescope mounted glasses, loupes, or we use microscopes. And the ideal position, just like Susan talked about, is that you want to have the shoulder in line with your ears. So your ear to your shoulder, you want that to be completely straight. You don't want any forward or backward position. And also, you want your arm to be at 90 degrees in an ideal situations. And the Ergonomics 101, job that requires neck flexion greater than 15 degrees of flexion forward is associated with a musculoskeletal disease, and this has been well documented. In our field, it's 45 degrees. Most of us spend during the surgeries, we typically lean forward for about 45 degrees if you're not using a microscope. So this is many of the pediatric ophthalmologists or the oculoplastics or retinal surgeons who are doing buckles. So, and why is this important? Because today we're doing more number of surgeries than ever before in history, because we have gotten efficient and our equipment is better. And this means that we're spending even longer duration in the operating room. And then also, to make things worse, the demand is growing, the population is growing, and we don't have the number of physicians that's growing in number proportionally. And that's why you see physicians, and when I go to India or when I go to some of these countries, it's not unusual for average surgeons to do, I'm not exaggerating, 80 to 90 surgeries a day. So, I mean, as you can imagine, the stress that they're putting on themselves. What happens when you're leaning forward in the operating room to the lower back? So if you could imagine, the disc that Ben talked about is like the shock absorber in your car. And the annular ligament is like the coiled spring that wraps around the shock absorber. And when you're leaning forward for a prolonged period of time, you're drying out the disc and you're shrinking it. And the disc space between the vertebra is getting narrower and narrower. And that's what induces the bone spurs and tears in the annulus, resulting in spinal stenosis with the disc herniations and eventually irritating the nerve nearby. Susan talked about this, the lateral flexion of the neck or back is even more dangerous because we don't have we don't have a annular ligament that's significant enough to hold the spine in place laterally. So it's mostly in the front and the back. but laterally, we don't have much protection. So this type of movement for 5 to 10 minutes, maybe you can endure. But if you're doing this for a prolonged period of time, this is going to cause significant strain on your disc. And also, the lateral flexion is very common among the pediatric retinologists and pediatric ophthalmologists, because when we're trying to look at the macula and we're trying to look into the 270 degrees of the retina, you only have a few choices. You could rotate the eyeball, rotate the neck of the patient, but you're going to have to tilt. You will have to tilt. So this is actually, we're in a very difficult situation. So is there anything that we can do? The answer is definitely yes. So first, let's talk about the surgical loops. This is something that I use on every cases that I do. But most of the surgeons are using the surgical loops that are not properly fitted. Please remember I said this. They're not properly fitted. So you had this thing fitted when you're a resident or 10, 20 years ago. But your body changes, your body habitus change, and also your optics change, your refraction change. So we're wearing glasses for most of us that are not properly fitted for us. It was at one point, but not today. And also these telescopes are heavy. So it's putting a lot of pressure on your nose and your ears. It's uncomfortable. And then it can further, and also these loops, the way it's designed, it can further exacerbate the neck flexion. And that's the reason why many surgeons refuse to wear surgical loops. And they're just doing surgery without any glasses, especially if they have the right optics. But we have now recently, like I'm going to say last 2 years or so, now the surgical loops companies have developed these special prisms. They can bend the light. And as you can see, with this prismatic corrections, it completely corrected my head posture. It does take a little bit of time to get used to them, but it doesn't take much. So with this I've been using these surgical loops now for about 6 months, and my posture is zero. There's no flexion whatsoever. So this is something that I would love to have you guys try, and you can have these reps to come to your office and you can try it, and make sure that you have the proper pupillary distance and working distance, and wear the proper glasses. And also surgical instruments, make sure it's sharp and lubricated. Let them know if there's any instruments that's not working properly, send them back and have them and this, your future depends on it. Make sure that these instruments are properly prepared, and try to avoid any type of flexion more than 15 degrees. And the way you do that is that you have to adjust a chair and bed and your microscope before the surgery starts. So don't try to wiggle yourself and try to adjust after the surgery, because it's too late by that time, because it doesn't work. So make sure you spend a couple of minutes, you sit comfortably, especially with the first case. That's the most important. Sit properly, make sure you're completely comfortable, and have someone else even look at you, and make sure that all the equipment is fitted to you, not the other way around. There are 3-dimensional display systems. I'm not going to talk about each individuals, but they do have definite advantages, because here there are 3 surgeons and a nurse looking at one small tiny organ, and you can see they all have to look at one small organ, and they're going to have to, someone is going to have to flex. It's going to be very difficult to cram everybody all together. So this is me using the 3D system. And so you can have everyone looking at the big screens, and we typically have 2 or 3 screens on the wall, and you can be doing surgeries in terms of whether it's cataracts, retinal surgeries, or strabismus surgeries. And there are many options out there, but the problem is that they're still pretty expensive, and it does take up a lot of space in the operating room. So I do think that there's a lot of potential for these technology, because it does help me. And I've been pretty happy with it. But there are more and more companies that are coming out with better equipment. And so I'm going to say 4 take-home messages. Number 1. have the OR staff take photos or videos of your postures during surgery. All athletes do this. For our profession, I think you owe it to yourself. Have someone else look at you. There's no way you can look at yourself, right? And then review those videos. Number two, like Ben was talking about, most of us don't have time to go to the gym, 2-3 times a day, 2-3 times a week. So between surgical cases, instead of being on the phone and things like this, for 2 minutes between cases, make sure you stretch. So 2 minutes, and let's say you have 10 cases, that's 20 minutes. That's pretty much what you need. And so have some of these weights in the operating room and have them provided for you if they don't. And then do some of the exercises that Ben talked about and stretch. I think that's extremely important. And then, of course, he talked about hydration. Again, this needs to be hydrated. And then third is that consider Prism surgical loops. There are many, pretty much all companies now have these Prism surgical loops. That's been available for about last 2 years or so, and it's actually getting better and better and better. And I've been pretty happy with it. And right now I'm actually doing EMGs, and we're doing a study trying to objectively quantify the muscle straining that we're applying to different muscles. And hopefully next time I present this talk again, we'll have that data available for you. And then also, you remember your body's changing, so make sure you adapt to it. So if your surgical loops are not designed for your body today, get it adjusted. And then number 4, pain, for us surgeons, it's almost like considered like a badge of honor. When I was in training down at the Baylor Medical School, it was a surgeon's mentality. It's like, you don't complain. Pain is okay. No, it is not okay. It's not a badge of honor. If your body is telling you that you're in pain, something is not right. You need to figure out what is causing the problem. And I think making those small changes that we talked about today, I think is truly critical. Charles Darwin, I was down at the Galapagos. There's a huge sign as you land off the plane. And the sign says that it's not the strongest or the smartest that survive. Of course, it's the most adaptable to change that will survive and outlast you. Well, thank you very much, everyone. And I'm going to let's go over some of these questions. I hope that was helpful. What are some of the suggestions for ophthalmic surgeons who are short?
I would consider putting your foot pedals on risers. That's one thing. So you want to keep your feet flat, and between the bed and your leg length, you need help there.
So next question, I'm gonna ask Ben this question. Like, for your retinal surgeries and cataract surgeries, what are some of the recommendations? And I kind of brought up some of the tips as well. But what are some of the tips that you can help you to make your posture better for your retinal or cataract surgeries using the microscope?
Yeah, I learned early on to try to do everything under the scope. So the biggest one is scleral buckles. It's a little bit of a learning curve to switch from doing it kind of the standard way to scope, but it actually has made my surgeries faster with a better view, and it has helped make my posture better. And I think what you said about spending, like, the more time you spend getting yourself set up properly in the beginning of surgery will save you time during the surgery. You'll be more comfortable, and I think your posture will be better. And then setting up your foot pedals, I think, is huge, right? Not everyone has the same hip alignment. My hips are actually a little bit externally rotated compared to like maybe like the mean person. So I need my foot pedals like probably like 20 degrees out or so. To be comfortable, for my hips. Some people need it more in, it varies based on that. So I think you need to find out what is like best for yourself, in your posture.
Okay, thank you. Thank you. Susan, do you have any other tips that you can share with us? You can unmute yourself, Susan. So what are some of the tips that you have about positioning the bed and types of the bed in the operating room? Any other tips that you can share?
Yeah, the bed, the patient's bed. I like the striker double angled headrest because it's not just you. You have this patient that's very kyphotic, and all of a sudden you have to deal with it. You can also put the patient in a little bit of reverse Trendelenburg to get the head flat or the eye nice and parallel to the floor before you start. You know, I think as far as short surgeons go, you know, the risers are good. I always tilt my microscope because it brings the microscope to me, the oculars, as opposed to being upright. And that way I don't have to get as close to the bed. My back is not leaning in as much.
Okay.
Those are a couple tips that I would give.
Okay, thank you. Thank you very much for answering a lot of these questions. Susan, since you're back issues, what are some of the things that you have changed? Just unmute yourself. Yeah, just leave it on. Yeah. So what's like one or two things that you have done that you think made the most impact? That improved your ergonomics? What are some, like if you say like one or two things that made the most amount of impact that alleviated your back pain, what would that be?
Raising the chair in the exam room.
Okay.
Not leaning in, forcing the patient to come to me. Because you're leaning in, mine is the neck issue and hyperextending my neck. If I can keep myself neutral, bring the patient towards me, I'm good.
Okay. So I'm a new ophthalmologist and have scoliosis and the thoracic lumbar since I was in middle school. Do you have any tips for my back? Can be in a good position so I can reduce my back pain. Thank you. Both of you, anybody?
You know, I would talk to your spine, who you see regularly as a physician, and say, what is the best position to keep me functioning for the rest of my life? And then try to adapt that posture in your work. And I would say it's going to be a form of neutral, but what's neutral for you may have some curvature, obviously, there. And I bet there's also exercises you can do as well.
Yeah.
I agree with Ben. I do my exercises twice a week.
Yeah. I don't know if I'm like not super comfortable knowing specific about scoliosis. You know, I think definitely talk to whoever, you know, does your spine for you. But in general, yeah, strengthening it is probably a good idea, but defer to your specialist.
Yeah, so this is actually, I feel very strongly about this. I'm just going to tell you, all athletes at a professional level have multiple coaches and multiple people that are constantly watching your posture. You know, golfers, I'm going to tell you, even Tiger Woods, you could quote me on it. I have multiple coaches that are constantly watching. I mean, these are people who are doing this, repeatedly, for millions of times. But they have coaches and they have trainers that are constantly watching. And we're all professionals. So I'm just going to tell you, a lot of the recommendations that Ben made, I think those are great. But I would highly recommend that you have a trainer, a professional trainer, or a physical therapist who actually work with you, at least initially. You may not have time to visit them like on a regular basis, but at least initially, so you get the right technique, because some of the stuff, the exercises that he recommended can really be detrimental and it can hurt you. It can backfire. So please, get a professional, someone that get our recommendations and talk to your doctors, or and get the professional physical therapists or trainers who deal with our people in our specialties. So next is that I had a whiplash injury, being a pediatric ophthalmologist and do lasers, ROP lasers. And every patient now, like when they're treating, every patient there, the person is having significant pain. Is neck collar, can you suggest if a collar can be helpful. Ben?
Oh man, I get, yeah, I don't believe that those tend to be helpful. I think, they um when you have supported devices like that, like, I haven't seen that specifically looked at in the literature, but when you have support devices like that, sometimes that can actually weaken, your natural musculature because you're relying on that. So that when you don't have it, that can lead to instability. So,
Yeah.
I don't think that that's recommended, but
I'm gonna actually make a recommendation. First of all, I don't think it's a good idea because when you have a neck collar, it actually limits the area that you can visualize. So if you are in a significant discomfort or pain, let me just tell you, I would love to do everything that I can, but sometimes you may think about some other options. So first, I would recommend that if you're in pain, do not ignore it. And second, I would get a physical therapist, or I would talk to your doctors about your concerns and seek help. And if they help, do not alleviate the discomfort. I would highly recommend that you look for other things and delegate the ROP treatment to someone else. That would be my recommendations. And I've actually had a partner, I had a colleague who actually had to retire early because of the RP treatment with the lasers. But fortunately, these days we have Avastins and we have other treatment modalities that are that have been effective. So I think that's great. And then this was a great comment. I would add, avoid high heels and shoulder bags. What do you think about that, Susan?
Oh, I think it's a great idea. Backpacks are much better. They distribute weight. So a shoulder bag obviously is very light. Or you do your farmer carry. Farmer carry is considered you carry your bag in your hand, not on your shoulder. And as long as you're symmetric and well positioned, and again, you can progressively load, as Ben talked about, but put your stuff in a bag that you carry in your hand.
Yeah.
I think it's much better. And high heels, yes, they're hard. We can wear them for short periods of time.
Yeah, I definitely, when I see ladies in high heels, I just don't know how they do it. That's just because if men have to wear them, I don't think anybody would. So I think that's, and then what strategy do you enjoy reduce? I'm going to just ask, these are a lot of great questions. I'm just going to stop here because, this is actually, this really is a topic that we can cover we can have a whole symposium on this particular topic. But I hope some of the tools that we talked about is helpful to you. And I'm hoping that we could have another webinar on this topic next year. So hopefully all of you would join. And thank you very much, everybody. And I hope you have a wonderful, safe, ergonomic day today. Thank you. Thank you, everybody.
Thank you.